Hello. Welcome to Meet the Trialist session by ESC TV at the 2022 European Society of Cardiology from Barcelona. I'm Biykem Bozkurt, Professor of Medicine from Baylor College of Medicine in Houston, Texas. And I'm delighted to be joined by Professor John McMurray, a Professor of Cardiology from University of Glasgow, a global leader in clinical trials, who was the principal investigator of the Perspective trial that we're going to be talking about. John, tell us about the Perspective trial. What was it and why was it designed?
Okay, so Perspective was a safety trial that was designed because a concern had been raised about the long-term effects of neprilysin inhibition on cognitive function related to amyloid beta peptide deposition in the brain. Now, what's all that about? Well, sacubitril valsartan, which we know well, is an effective therapy for heart failure because sacubitril inhibits an enzyme called neprilysin. Neprilysin is responsible for the breakdown of natriuretic and other vasoactive peptides, and if we inhibit neprilysin and increase the amounts of those peptides, it has beneficial effects in patients with heart failure. But the hypothetical concern was that neprilysin is also one of several enzymes that break down amyloid beta peptides. Sacubitril crosses the brain barrier, and therefore the concern raised was that chronic neprilysin inhibition might lead to accumulation of neurotoxic species of amyloid beta peptides. And of course, there has been a prevailing hypothesis that Alzheimer type dementia is related to accumulation of those peptides in the brain. So this trial was really designed to test whether any of that hypothetical concern was actually true. Now, I have to say hypothetical because there are, last time I looked in the literature, about 20 different clearance mechanisms for amyloid beta peptides in the brain. So there's lots of redundancy. So it was always likely that even if you did knock out one enzyme, neprilysin, the other clearance mechanisms would compensate. But nevertheless, the regulatory authorities were very keen that we did a safety trial to try and address this concern. So that's what Perspective was about. Now, I don't know if you want me to go into the...
Absolutely. Tell us, who the patients were and what was tested in this trial. What
Sure.
were the results?
Okay. So we enrolled patients with mildly reduced and preserved ejection fraction. People have asked, why did we do that? Why didn't we?
I was going to ask that. Tell us why
well,
just the PEF, not the REF?
So we felt there was an ethical obligation to treat REF patients with sacubitril valsartan. This was a trial where we compared sacubitril valsartan to valsartan. We did not think that valsartan was the best treatment for patients with reduced ejection fraction. But we did not feel there was any imperative at the time that we started this to give sacubitril valsartan to patients with an ejection fraction above 40%. So that's why we chose this population. And in fact, in terms of looking at cognitive function, older, more comorbid patients with a lot of hypertension, atrial fibrillation is actually a very good substrate to test whether or not there was something happening to cognitive function. So we screened a lot of patients, and we randomized 592, just under 600. And the primary endpoint was cognitive function. A very important secondary endpoint that we studied in a subset of patients was amyloid beta peptide deposition in the brain, and we measured that using serial PET imaging. We had a special radio tracer that selectively, specifically, sensitively identified amyloid beta peptide accumulation. So each of the patients was studied for 3 years. We wanted to do as long-term a trial as we could, but realistically there is only so long that you can keep people in trials, and especially one as complicated as this, where people were coming back for serial MRI, brain scans, serial PET scans, and of course doing serial cognitive function tests. So we negotiated with the regulatory authorities and we came up with 3 years being a reasonable length of time in the lifespan of a patient with heart failure. So in the trial we did cognitive function measurement every 6 months, and you know how we did that. The patients had a little iPad, and this was loaded with something called the Cog State battery. So there are 7 tasks on this, 7 tests.
Tell us about this test. It's fascinating.
Okay, so
cardiologists don't know this, but neurologists use it all the time.
Yes, so this was, I should have said, you've reminded me, of course, that although I'm talking about this was a real team effort between 3 groups of patients, so people like me, Scott Solomon, heart failure doctors, some Alzheimer's disease researchers, and neuroimaging researchers, because we needed a special team to do this. So the Cog State battery, it's a proprietary system. You can look it up online if you're interested, take some of the tests. But I presented 2 examples today in the hotline. For example, one very simple test is on the iPad, a playing card is presented, and the card may or may not turn over, and the patient has to say whether or not it turned over, and the speed and accuracy with which they identify that, press the button to say yes, it's turned over, is one of the cognitive domains. The other one I presented was the one back test. So the card presented on the iPad, is that the same or different from the last card that you looked at? And again, you answer yes or no, and the speed and accuracy with which you do that again assesses one domain of cognitive function. There's another test which is working your way through a maze, and then there's the international shopping list test, which asks you to remember lists of groceries. So these are all anybody who does this knows all of this, very standardized tests, 7 of them, and they test the 3 major cognitive domains. So we did that at baseline, and we did that every 6 months. And the brain imaging we did at baseline at 18 and 36 months.
What did you find?
What did we find? So I think I break that down into 3 bits so that I don't keep talking all the time. So the first bit, I think, is what we found at baseline. So I think that is maybe as important as anything else, because what we found was that compared to men and women of the same age in the general population, for some of the cognitive function domains, 60% of our patients had cognitive impairment. Now, you know that we deliberately excluded patients with clear, overt cognitive dysfunction at baseline. We didn't want to include patients with dementia. We didn't want to include people with a very low MMSE score. We didn't want to include people who were on treatment for cognitive dysfunction.
And you even excluded cerebrovascular disease. So these individuals were, in essence, not
relatively, and yet when you do these very sensitive tests, and these really are remarkably sensitive to recognizing cognitive impairment, we found that about 60% of people for some of the tests had some degree of cognitive impairment. So over the 3 years of follow-up, there was a gradual decline in cognitive function, which in itself is interesting because you don't always see that in different populations. So for example, you don't see that in a hypertensive population generally. And maybe the important thing was there was no difference between sacubitril, valsartan, and valsartan. So in other words, neprilysin inhibition in this adequately powered study using sensitive tests for cognitive impairment, we did not detect any difference. Now, we used a special statistic, not, I think, well known to cardiologists, but used a lot in behavioral sciences, which is something called Cohen's d, or standardized mean difference. And that is a way of quantifying the effect size. And our Cohen's d was minus 0.02 something. It was tiny, and that equates to a trivial difference between the two treatments in cognitive function. And then maybe the third and final thing to say is that the amyloid PET imaging showed again that there was, even in that 3-year period, an increase in amyloid beta peptide deposition. But curiously, in all but one of the different regions of the brain and in the brain overall, if anything, there was a trend to less amyloid deposition in the patients who received sacubitril valsartan than in the patients who received placebo. I don't know whether that's a chance finding or whether, as trials often do, surprise you by showing the opposite of what you expected to find in the first place. But we didn't see any signal for beta amyloid deposition. So as far as we can tell, and I mean every clinical trial has its limitations, this was around 600 patients, but that is big for this sort of study, and as large as any, for example, typical Alzheimer's disease trial. We really didn't see anything. So I hope it puts that safety concern to rest, because I think we know, because we talk about the treatment of heart failure all the time, that there are some doctors out there who were concerned about this. And I'm glad that we've done this, and I think it closes a chapter in the whole sacubitril valsartan story, which we started way back with Paradigm in 2014.
And the significance of the trial is that it is the only randomized clinical trial addressing the neprilysin inhibition effects on the brain in the heart failure population. There are no other trials looking into this, and actually supports the former clinical trials, which didn't show us any signal, right? We didn't see any dementia signal, cognitive impairment in Paradigm, Paragon, Paradise MI.
Yeah, so we, in Paradigm, you're right, we looked at dementia and cognition-related adverse events. Now, you could argue that that's relatively insensitive, and Paradigm was relatively short-term, and those were much younger patients. So that's a criticism of that analysis. In Paragon, we did do serial MMSE testing, and that didn't show anything, but you could argue that MMSE is not a very sensitive test of cognitive dysfunction. So yes, the totality of the evidence, clinical evidence, doesn't show anything, but this was really the more definitive study to address that specific question.
It was very reassuring to see the lack of harm with sacubitril valsartan, but it was also an eye-opening finding to see the amount of cognitive decline the heart failure patients manifest. Do you think we should be doing cognitive function in a sort of a standardized manner, either in the clinical trials, to look at either indirect effects? Are you planning to do any responder analysis to see what's happening to those individuals who are getting better with either of the agents and their cognitive delta changes over time, and amyloid beta? Because that was fascinating.
Well, this is a very rich data set, and there were a whole bunch of other secondary endpoints. We've got many other questionnaires. Problem is, we've had these data for a very short period of time, so I'm hoping to dig into many of the things that you've mentioned for sure. And as you know, we've even got ApoE4 gene testing on everybody, so there's lots and lots of interesting things to look at. But to go back to your first question, which is a really interesting question because a few years ago, I remember being very embarrassed in some ways in that I recruited a patient into a clinical trial, and then this patient stopped attending for follow-up visits. And we sent one of our research nurses out to the patient's house, and to cut a long story short, it emerged that this patient had quite marked cognitive dysfunction. Now, I had personally met this patient on several occasions for at least 2 years in a clinic, and we'd gone through the usual, how are you doing, how are you getting on, tell me about your symptoms, hop up on the couch, I'll listen to you. And I never recognized that because many patients can carry out what appears to be a normal routine conversation of the sort of fairly brief type that we often have with our patients. We go through a list of questions, they answer yes or no, you exchange some pleasantries, and I had not recognized that this patient had significant cognitive impairment. So actually, I think you're right. It is much more prevalent than we realize. And in a separate study that we did, sort of an institutional investigator-initiated study that we did a couple of years ago, where we did these very sensitive sorts of tests that we just discussed, that battery of tests. We also did the MoCA questionnaire and actually found that MoCA is quite sensitive. It's not quite as good as these sort of battery of tests, but it is a very good balance between time and complexity and simplicity. It's much better than MMSE. And interestingly, we didn't use MoCA in this trial because in some countries the MoCA test has a legal implication, because in some countries if you score poorly on the MoCA, you can, for example, have your driving license revoked and so on. So there are all sorts of ramifications of what we're talking about in terms of the impact for our patients. But today we heard an amazing trial about a polypill perhaps leading to better adherence, leading to better outcomes. And you can imagine that if you're cognitively impaired and have a memory impairment, you may not take your treatment. So cognitive impairment has major implications for both the care of patients and their outcomes.
I think the points you underline, our inability to recognize subtle differences in our routine interactions with the patients, even sometimes creates that inertia of not acting, because the symptomatology we ask is usually, I'm fine, doc. And thus, I think sensitivity of these objective testing was truly fascinating for me to see, and also repeatability over time. I would like to invite our audience members if there are any questions, and I will just pose our last question for John while any of you may be coming to the podium or to the microphone. Any perhaps subgroup analysis in mildly reduced versus preserved, and or perhaps should we look at what's happening in REF and or individuals with cognitive decline? They may have a different, threshold or blood-brain barrier issues.
Yeah, so good questions. I mean, the subgroups that we've looked at so far, we haven't seen anything. I have to say the one that I focused on, mainly because you asked me, was the ApoE4 subgroup, and there's no obvious difference between treatments in that subgroup. But yeah, we're going to have a look at lots of things. Blood-brain barrier, I truthfully don't know the difference, but you have made me remember, so my cognitive function is okay, I think, that in our previous investigator-led study, we did have patients with HEF-REF and HEF-PEF, and the extent of cognitive impairment was pretty much the same. Interestingly, the group who stood out in that study by a long way, the ones with the greatest cognitive impairment in both major ejection fraction phenotypes or patients with concomitant atrial fibrillation, possibly giving us a clue to why patients with heart failure often do have cognitive impairment. I strongly suspect that thromboembolism has a role to play, but there may be other things. I also wonder about cerebral blood flow in patients who've got atrial fibrillation compared to patients who don't.
With that, I would like to thank Professor McMurray, the investigators, and the patients who participated in the prospective trial. These are truly fascinating results, and our audience for participating, and look forward to seeing you in the future sessions. Thank you.
Thank you.